I'd like to introduce Travis Hodgson, Chief Operating Officer of Healthdirect Australia, Julie Ayre, a Research Fellow at University of Sydney, and Julie Sturgess, CEO of Country to Coast Queensland. Welcome. The internet has given us powerful tools to consult doctors remotely and organise healthcare services from afar. But how successful has this really been? Are different communities and socio-economic groups making meaningful use of these services? Do they know they exist? There's lots of questions around this, and we're wanting to work through this issue. So, Julie Sturgess, just tell us a little bit about what you do, and then we can have a couple of questions around that. But
Sure. So, Country Coast Queensland delivers the primary health network program across a big area in Queensland. So it includes the Sunshine Coast, which is the big region, Wider Bay, another big and Ellsworth region, and it's central Queensland, so very remote. So it's a really interesting demographic area to work with because there are big distances, lots of disadvantage, and a lot of need and demand. For those that don't know, the Primary Health Network program is funded by Commonwealth Government, and the focus is on improving health outcomes in primary care for populations.
are the people there aware of the services? Are you providing virgin services? What is the take-up lie in one of the roadblocks to issues?
Look, I think it's an interesting question, and I think as a primary health network, we spend a lot of time trying to drill down into the reasons for that, and the reality is they're complex, or not complex actually, as the case may be. But also we look at health outcomes and we look at uptake of virtual services. What we see is that there are some factors that are really big contributors to not only the burden of disease, but also the uptake of virtual services. And so, what we see is with certain groups, Aboriginal and Torres Strait Islander populations who demonstrate a really large burden of disease, but very low levels of digital inclusion and uptake of virtual services. People who live in remote areas, again, poorer health outcomes, but poor uptake of virtual services. People in the long socioeconomic defaults, poor outcomes and low uptake services. And so what we see is there is this real correlation between those things, and that's not to say that they're dependent on each other. I think what we would say as a health network is the factors that contribute to poor health outcomes also contribute to poor uptake of virtual services. And that's because, financial insecurity, insecure housing, low levels of education, low levels of social connection, and those two things deliver bad health outcomes and actually inhibit the uptake of virtual services as well. So yes, it's a problem, I guess, that we would say can't be solved by one solution alone.
Dr. Julie, people attribute the problems with access. Is it deeper? What about barriers such as trust, digital literacy, cultural religion?
Everyone kind of understands the sector that I'm related to this in the Sydney Health Literacy Lab at the University of Sydney. So I'd really focusing on health literacy skills, and I think that's relevant to this question as well. So yes, access to smartphone devices, things like that, connectivity, access to data is really important. But from a health literacy perspective, we can also think about things like, do people have the skills that they need to be able to access, understand, create and use health information services as well? I think for me, I did some research during COVID-19 in Western Sydney, and that was a really good demonstration of kind of what role does health literacy and digital health literacy play in that sphere. So some of the things we saw were that, because mass public health communication probably goes so far and doesn't necessarily reach all the groups that they want to reach. The response to that was to work really complicit with the communities and find out what it is that they actually need. And it's not just about, covering the website, but support them. It's about who's delivering the message. Is the message clear and easy for them to understand? Is it being translated? And is that actually resonating with them as well? Is it something they can actually act on? The second thing he said, COVID, is that there is so much misinformation online as well. For the people who are connected to the internet, for them to be able to find out, should I go and see a GP? What should I do to look after my health can also be really hard. So that piece about thinking critically about which this is of information you should trust is really important there in terms in particular to buy it as well.
Yeah, I think one of the problems is, and I guess it's objective here, is that people not necessarily know what some of the services are that are out there. They consult, as you said before, Dr. Google, with disastrous consequences. They try and self-diagnose, people try and get themselves medications that are more suitable. And, it's a random guess as to what the results are. So these are very important services provided by government, but it's a question of access and knowledge of that. Travis Hodgson, are current key performance indicators like call volumes and wait times tell us anything meaningful about access, equity, outcomes? Other measures wouldn't unfold, should we be looking at something else?
Thanks, Chris. Travis Hodgson, Chief Operations Officer at Healthdirect Australia. So Healthdirect is a government entity global to state territory governments as well as the Commonwealth to deliver health information, care advice and virtual healthcare services to all Australians regardless of where they live or their capacity to pay as a free service. We support billions of Australians each year in navigating this complex health and care system. So economic rationalists would probably say targets like volume of falls, speed to answer, some of those technical indicators, activity-based indicators that are super important to measure concepts of technical efficiency. But of course they're the right indicators, but it depends on which side of the scorecard you see on. Reflecting on Julia's comments a minute ago, there needs to be greater balance, absolutely emphasis on health equity in particular. And when we talk about health equity, again, equity in terms of whose perspective. So is it equity of access? Is it equality of health outcomes? See, there's always an intrinsic link between two. But when we talk about the investment cycle in urgent care post-COVID, it's less about volume and more about value. And so the metrics that define value impact things like beyond the indicators you mentioned, things like avoidable emergency department presentations, reductory to potentially preventable hospitalizations, particularly for people who are residing in areas of greatest challenge to access care services, to engage in healthy lifestyles. Access to food security is a challenge. There would be Julie Sturgess touched earlier on, the societal, the social determinants of health. And so, increasingly, if we're talking about metrics, and how do we make sure we're starting to not even put policy implementations upstream to reduce illness occurring to start with, a dry demand, and if we'll get distracted by these types of indicators, but actually measuring some of the sociology aspects of healthcare and of determinants, because it's less about biological determinants, it comes from more about sociology determinants. So all of those components of health equity come into play when we talk about accessibility, in particular, whether it's in language, whether it is something that's something that First Nations population would identify as feeling culturally safe and culturally inclusive. Fulfilling one use health ambitions to the absolute potential that can be achieved is the ultimate goal in health equity.
Thank you very much. Julie Sturgess, there's a lot of hype around local commissioning, great technology innovations at the local level, some of which are doing the rest equity and access, but there's some apparently that are distractions. I mean, have you encountered these concerns, and what would they?
As a primary healthcare worker, I hear those concerns every day, and obviously our mandate is very much to our understanding the communities that we serve. So I think it's important. And back to Travis's point, from our point of view, driving equity and health outcomes is about really preferentially advantaging those populations that are most disadvantaged. And I think you need to know what that is at a local level to be able to tailor solutions to the needs of those populations and the things that will work for them. That's not to say that I don't think there are national virtual care solutions that aren't very helpful, and certainly in our region, one of the things that we implemented in the last couple of years is actually we developed with Healthdirect a virtual mental health intake model for mental health. And I think that took a lot of work because you need to design it to the needs of the population, the clinical service needs of a program, but also that there's a lot of tailoring that happens to fit within the local service context. And I think very possible if you don't have the partnerships that you need to actually do that at a local level. But I also think you need to be able to take advantage of national infrastructure to drive the efficiencies that Travis was talking about as well. I think just understanding some of those cohorts, though, are really critical. So I think they're really good examples of great technology being implemented using national infrastructure and being implemented locally. I think there are some not so great examples, but what our colleagues say is that I will use the technology as an example of that. I would use maybe the way it's implemented, and I think we miss a lot of opportunities in the Australian context to actually grow virtual care and tailor it to what we need. I think a great example is Julie mentioned this. Some of the absolute developments that we saw in the disaster space during COVID, in my experience during floods and natural disasters, and you see this willingness of an entire community to adopt new models of care, which I think are fantastic, but what we're not doing as a country, and I think funding and policy doesn't drive this well enough. Hold on. Is it Marine? Is that, we talk about bouncing back after a disaster and everyone goes back to normal, but in reality, if we had so many gains during that disaster, why aren't we bouncing forward? Why aren't we taking the opportunity to embed virtual care and the opportunities that it provides to improve access and embed it as business as usual? So the next challenge is a different challenge. So I think, if I'm not going to attack the technology per se, I think I'm going to attack not attacking, actually, but I think I'm going to say I think there are improvements for the way that we can actually embed that into the future. So, and I'm constantly revisiting those sort of things.
Right, thank you very much. Julie, AI, of course, is an interesting issue because, you want something with a human interaction or people who are sitting here virtually want that. What meaningful roles could it play in delivering virtual healthcare? Are there specific use cases that would be exciting? And where should we draw the line? Where is it not viable? Should human contact always remain central to virtual care? Or are there contexts where AI-led interactions might be more effective?
That's a pretty big question.
Sorry, that's too many questions.
But I think just a couple of things that I'll put into that answer. Firstly, the AI, from a community point of view, I think the AI shifted the sales. So we know from Australian research and people are using tools like ChatGPT for goals. The most common question that people ask ChatGPT is how much my pitch me, right? And also that there's a social gradient to using these kinds of tools. So in Australia, we're researching a low cost literacy who state that like Jacory Walker people are more likely to be using ChatGPT. There's some US research that stands people who don't have a regular GP who are likely to be using tools like ChatGPT for health information. So there could be this emerging picture that it actually is an equity issue that we need to grapple with as well. The second thing that I would say is that I think a lot of the technology is at a point where it can actually get really useful. Not off the shelf, kind of just throwing things into ChatGPT. We need to be working towards using those technologies to build solutions that have equity and accessibility as a core component of how they're designed. That means partnering with stakeholders, whether that's the best services, but also communities and consumers to really make sure that there be those needs of their staff means that they're already working really well. You know, you mentioned having a human contact and a human in the loop, and I think that's kind of that's obviously where they started off, and then as they become, as they're grunting and evaluating how these technologies work, we can kind of move forward in terms of something that's more candid or coming up with solutions where they the information in an AI portal with clinicians to make sure that it's safe before it goes out. And the last thing that I just wanted to mention was that I think it's really easy to focus on these AI tools to be perfect, but what we need to keep in mind is that what is the alternative? So for someone who has limited English proficiency and is having trouble accessing services, what is the alternative for them without these tools? And what does that mean for their outcomes as well?
Thank you very much. I guess AI's invitation in the health sector generally is a huge issue of subset being virtual health, just about hiding health and things like that. So I guess we're all kind of working to try and come to terms with those innovations along the way. James Hodgson, based on your experience across national and state health systems, is government policy genuinely enabling equitable virtual care, or is it creating more red tape than results? What's your view of that?
So, look, it's a big question. I think in balance, domestically here in Australia, I think our governments have done extraordinarily well in the maximum developed nations in investing in healthcare models that are accessible in the country. Its population is so geographic, but it's no force yet that we do have other overseas. The majority is the east to the suburb of the country. Yet we still have the ability for people to go for their own communities and that. But the open style and for an unnecessary plane trip from Nullarbor to the Northern Territory, the Boldale still where historically that nephrologist would need to visit Fort Riley to get that patient's diabetes management clinic to control. So I think the first point is around our governments enabling these models of care to not just kind of survive, but to actually thrive. I would argue certainly the last few years on the back of COVID, we've seen an acceleration of the investment, adoption and acceptance by the most important people in the healthcare system, patients themselves. Government faces a real challenge. It's got the challenge of appeasing many stakeholders, right? Regardless of if you're a state or Commonwealth government, there's a whole range of different perspectives and expectations of those different audiences and players and actors have. Now, if we look at, for instance, the space of virtual care, driving the adoption of AI, just as one example. The trending of AI, I'm sure, has crept into every single one of these pages, this conference. In fact, it's creeping into nearly every email I receive from technology vendors offering to do free AI demonstrations and all kinds of show fasts. In the space of AI, I think government clearly have a very important role to play, setting the guardrails. The regulators in the portal have a very clear role that is about setting guardrails to protect safety, quality, and data sovereignty in particular. Now, The change is making sure that government is seen as an enabler and not an anchor. And I think the way of avoiding to becoming an anchor is ensuring that you've got adequate design of what those guardrails are, how they should be applied and why, and then enabling industry, consumers, practitioners, the whole care system coming together from the different viewpoints in its application, so that when it comes time to driving implementation and measuring adherence from a regulatory perspective, everybody has experienced an inclusive approach is designed to be practical or hopefully something that people find more easy to navigate rather than rules coming down for government, legislation getting passed and coming back to rotation for something that won't necessarily be enduring broad footprint.
Thank you very much. Just for any of you, in terms of customer experience, to use a generic term, do we see in the systems that you're all involved in, consumer fit course, co-design, if you like, in the type of services that are available? Are they used to make them more accessible and easier for them to navigate? What do you think?
I would say from our point of view, it's a cornerstone. It's a way we try and develop services, and particularly when we're developing, solutions which involve virtual care as an example. We involve stakeholders from across the system, so not just consumers, but service providers as well, because we want solutions that are actually meaningful to implement in a pragmatic way. All we find from consumers, particularly with the virtual care models that we've been designing, is that they're memory amenable to the opportunities of both AI and virtual care models they presented. But I think it is about having the information they need to feel secure about trusting the services that they're getting. And when they're provided with that information, the feedback is overwhelmingly that we would prefer to have these services than what is often the case, and there is no services at all. And so, I would say from a primary health network perspective is critical to the way we do it. And what we've seen in the services line, the health line that we've implemented, is focused on how we provide one point of navigation for consumer-centred system, which is a big part of the problem that they face, navigating, as you said, where to go and what services to access. And we designed the service system around that navigation as well. And what we're seeing is that our volumes, and I compare this to volumes nationally, around people accessing those mental health services, our volumes are ever increasing and by far way above any other area in the country. And I think that's because we built the service on what consumers need. And over time, we've built reliability, trust, and value for them, because when they engage with the service, they've been able to navigate to the point where they felt like their home stopped. So I think it's imperative, but I think there's a lot of that going on.
We're getting near the end, but I want to give you all a chance to have some final thoughts or talk about things that really are on your mind that we haven't been able to discuss in Sarah. I'll start with you, Julie Ayre. Have you got some thoughts that you'd like to get out now?
In just that co-design piece is extremely important whenever we're thinking about the accessibility. I think there's been doing some research recently with Healthdirect that has been very interesting, and we hear again how people think about AI in context of the government health service, and there's so much with trust there. But we know that trust can be really quickly eroded as well, so we need to be careful about the income, what's exposed, so that we maintain that trust and still provide these other benefits that we have through that.
Jobs.
Look, I might just say one thing, and then I want to make a comment about the question posed to Jules. pilots. We've got to kill it. There's too many popping up. It's whack-a-mole at the moment in digital health. But there's some really interesting new terms being provided now, like early implementation or phase 1 implementation, demonstrate projects. We've really got to take a step back and think about problems we're trying to solve, rather than continuing to kind of lay out technology on top of solutions that we as executives in the health system or researchers in the health system or commissioners in the health system believe we know all of the challenges that people are facing without actually asking them and validating with them, and then fundamentally co-design with them. If Clementine was with us, I'm sure she'd say something like, nothing about us without us. And in healthcare organisations that are devoted to continuous learning, that's a principle that rings true in all your design methodology. Whether you're developing solutions for practitioners, or consumers, because usability translates over time to repeated utility. And for mental health, that's certainly a key ingredient to success in our program. We're not in a business of creating, stickiness with consumers for ongoing care, in some cases episodic. But when we have people coming back with new problems or different problems, but with an increased level of health literacy or digital literacy, because we've built the framework of accessibility around inclusivity, that means we're actually shifting the dial around of care equity.
Jules?
Gosh, so much to speak of it. I find it hard to talk about digital technologies and virtual care without just recognising that, fundamentally there's some work that needs to be done around understanding why the most disadvantaged people don't have health outcomes to start with, that don't access virtual care and don't access any health care at all in some places. So I think how we work collectively, knowing that it's a system that actually makes that change, and for us, our commitment to working with other partners across other sectors to make those things happen really important. And so I think designing your healthcare alone, we're missing the point. For us, part of our inclusion strategy is we work with all of our local councils who beautifully have now implemented hubs in all of their viaries to allow access for people who don't have access to digital technologies to access services. And so that's cost us nothing, actually. It's cost them something because councils have supported that. And I think until we start embedding digital solutions in health with digital solutions across all of those other sectors, we're probably missing the point about how we bring it together anymore.
I think that certainly is true about issues of access in most communities. I still think that there's probably in the general public, even me in the role of exploring, is not having been aware of services that are out there, and I think that that's an issue generally, and as well as in the communities you talk about, but just to find that they're about. I'd like to thank you all. I think it'd be interesting to have this discussion in a year's time, because I think we'll see with AI and a number of these emerging medical support, health support platforms, we'll see a lot of activity in this from us. It's just got that vibe about it, and be interesting to reconvene and hear how you feel about that. So thank you very much this afternoon. It's been lovely to have this discussion. Please start the panelists.